Alright, we're going over other lab values. The first lab value is fecal fat, and the range is 5 to 7 grams per 24 hours, and it increases with pancreatic digestive enzyme deficiency, pancreatitis, cystic fibrosis, bile duct obstruction, and any impaired intestinal absorption. Also, it tests the amount of fat, but not why the amount of fat may be high. The next value we're going to go over is blood urea nitrogen, and the value for that is 10 to 20 milligrams per deciliter, and it measures the amount of urea in the blood, and it also is indicative of the daily protein intake. So it increases when you have decreased kidney function, dehydration, GI bleeding, stress, or protein catabolism, and then it decreases with overhydration, liver damage, or low protein. Also, it changes daily. The next one is creatinine, and it's an indicator of your muscle mass. For males, the value is 0.6 to 1.3. For females, it's 0.5 to 1.2. It increases with impaired renal and it also increases with rapid muscle loss, surgery, or trauma. But it decreases with decreased muscle mass in elderly people and also muscular dystrophy. Other is that it's a byproduct of muscle metabolism when creatinine phosphate forms ATP. It's produced at a constant rate, and it's based on a patient's muscle mass and their kidney function. It's also interpreted in conjunction with BUN, and it's not affected by dehydration or malnutrition. The next one is the BUN to creatinine ratio. So the usual ratio should be 10 to 1. If there's dehydration, it should be around 15 to 20 to 1. But then the thing to remember is that in renal disease, it's actually going to be the same as what it would be usually, but that's only because the BUN and the creatinine both rise proportionally. Kate's going to do the rest.
All right, here is serum sodium. The normal range is 135 to 148 milliliter equivalents per liter. Let's see, it is going to increase with dehydration, an increase in sodium in IV fluids, hypoaldosteronism, and excessive sweating. It will decrease with overhydration, CHF, water intoxication, and peripheral edema. And you want to make sure this is a measure of hydration status, not hydration intake. And it is used to show a sodium and water balance in the body. All right, and here we have hyponatremia, which is going to be low serum sodium. The cells are going to swell because water is going to be entering the cell. It causes lethargy, confusion, convulsions, and possibly a coma. And hypernatremia, which is an increase in serum sodium, it's going to be an intracellular dehydration where water will leave the cells. It causes thirst, tachycardia, and seizures. Serum potassium. The normal range is 3.5 to 5, and then it is essential for neurotransmitter contractions in conjunction with the sodium-potassium pump. You always want to remember that potassium is going to be pumped out of the cell and sodium into the cells. And with increased serum potassium, you're going to have kidney failure, it's caused by kidney failure, uncontrolled diabetes, and dehydration. And effects of it are going to be confusion, cramps, vomiting, and cardiac arrhythmia. And decreased serum potassium can be caused by PCM, diarrhea and vomiting, or potassium wasting diuretics. And they're going to cause muscle weakness, cramps, and again, cardiac arrhythmia. Serum calcium, the normal range is 8.4 to 9.5 milligrams per deciliter. Increase is going to be caused by hyperparathyroidism, long terms of immobilization, and metastatic bone tumors. Decrease in serum calcium is going to be caused by hypoparathyroidism, kidney failure, and osteomalacia. Half of the serum calcium is bound to albumin, and so if the albumin's low, it's going to give you a false low calcium. So to fix that, you want to use the corrected calcium over here, and the equation is there. It's going to be 0.8 times 4.0 minus the patient's albumin status, and to that you want to add the serum calcium, and that will give you the corrected calcium. Lastly, we have serum phosphorus. Normal range is 2.7 to 4.5 milligrams per deciliter. It's going to increase with kidney failure, non-compliance with binder therapies for those who are on dialysis or have kidney disease. And it is going to decrease with hyperparathyroidism and with refeeding syndrome. Oh, stop.